Welcome back to Missouri DMH's Deaf Services Training. This is Unit 4, and in this unit we'll be discussing dysfluency, literacy, and fund of information. To start off with, dysfluency is obviously the opposite of fluency. It's an inability to speak, or in our case, sign fluently in any language. Now, when we're talking about fluency, again, we like to use a spectrum here. There's a spectrum of fluency, of levels of fluency. Now, if you take a look at this slide, here's a spectrum that Dr. Pollard used in his online training, and we're going to use in this one as well. On the far left-hand side, we have incoherent, minimal language skills, comprehensible, proficient, fluent, and eloquent. It's important to understand that there are a variety of different types of fluency, not just the black and white, you're either fluent or you're dysfluent. For example, I'll use foreign language on this. So when I sign, I would say that I'm a fluent signer. When I speak English, I would say I'm a fluent signer. I took several years of Spanish in elementary school, high school, college. My Spanish, I'd put maybe comprehensible. And my Korean, I would probably put not even close to coherent. So different languages may produce different levels of fluency. Different types of hearing or hearing levels may produce different types of fluency. Different experiences in education, different experiences in those windows of developmental opportunity that we just discussed in our previous session may influence where a deaf or hard of hearing person falls on this spectrum of fluency. As we get into this, let's discuss just a little bit about how does anybody achieve fluency. Let's start with spoken language. How is spoken language achieved? Well, for you as a possible hearing person observing this training, ask yourself, how did you become fluent in English? You may have learned from your parents growing up, from the community, from visitors to your house, from hearing the language spoken on TV, radio, other medias. You are bombarded early on in your life and throughout your process of development by your spoken language. At what age would you maybe say that you became proficient? Maybe 4 years old? Maybe by 6 you were fluent? But now when we compare this to sign language or to a deaf or hard of hearing individual, obviously there's going to be difficulty there in accessing and becoming fluent in a spoken language without learning that from family, community, hearing it through TV, radio, media, so on and so forth. But how do they acquire fluency in a signed language? Linguists will tell you that achieving fluency comes from one of two things, either being exposed to the language early or having a prolonged exposure to the language. So if you remember that statistic I gave you earlier, 90+% of deaf individuals being born into hearing families, 93% of those hearing families never learning or acquiring any level of sign language. How does that get passed on to the deaf individual? Just like we found in the deaf culture section of this training, culture and hearing families are most often passed down vertically. Culture for deaf individuals are most often passed on horizontally. And likewise, so is language. Language and American Sign Language for deaf and hard of hearing individuals is most often passed on horizontally. It comes from peers. It comes from exposure later in life once they maybe go to a deaf school. Maybe they run into a community of deaf individuals and are able to interact and socialize and learn the language from them. Think about the implications for this in language fluency in the deaf population. There's a much different distribution on that fluency spectrum for deaf individuals than there are for hearing individuals. It is much more likely in deaf culture and with deaf folks that more of them will fail to achieve fluency in American Sign Language than hearing individuals learning English. If you take a look at this slide, this is my amateur attempt at replicating a slide Dr. Pollard put together in his online training to illustrate the differences between hearing and deaf fluencies. I think this shows the point, though. The majority of hearing folks looking at this slide tend to fall on the fluent side of the spectrum, whereas more deaf individuals will fall on the minimal language skill, comprehensible side of the spectrum. Dr. Andreasen from the University of Iowa's Department of Psychiatry was able to identify and describe 20 different types of dysfluency. As mental health professionals, I'm sure that some of these sound or look familiar to you. I'm sure that you've learned in your education and in your experience about some of these. Each one of them has a specific definition and has a specific description of what it looks like. In order to better categorize all these different types of dysfluency, I want to break them down into two basic types. There are psychiatric or medical dysfluency. This tends to be things like bizarre ideation, clanging, which is a focus on sentence structure, saying words that rhyme or words that sound similar in a sentence. In the deaf world, obviously, words that rhyme or sound similar does not apply. So we tend to see this in the deaf world as signing using similar hand shapes. For example, the hand shape for B. A deaf person might use this only hand shape to try to communicate, and that is a deaf version of clanging. The other basic type of dysfluency that we see is social dysfluency. We tend to see this often in deaf and hard of hearing communities. This is dysfluency from a lack of exposure, from a lack of education, from a general lack of development on a social language level. This tends to manifest for deaf individuals as not correctly understanding how to communicate tense. If you remember, in our American Sign Language unit, we discussed that tense is set up first, where we say, next week I will blah, 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 blah. Maybe a deaf individual that has social dysfluency is not able to do that or doesn't understand how to do that. Maybe in their signing they have the correct location on the body, but their palm is faced the wrong way. Some of these small, at times difficult to notice differences indicate a social dysfluency. So obviously it's very important to understand whether dysfluency is from a psychiatric or medical issue, or whether dysfluency comes from a social origin when working with a deaf or hard of hearing consumer. So how do we diagnose this? How do we figure out which of the two camps it may fall into? Well, the first thing that you need to find out or determine is the history of the fluency. Is this dysfluency that you're noticing in the client recent? Or has this been a lifelong problem? Has the type of dysfluency changed over time? Has it evolved over time? Or has it been fairly consistent? We tend to find that inconsistent fluency levels are more social in nature. For example, maybe they use the wrong tense in certain situations, but maybe in some situations they know how to and they use it correctly. Maybe they sign with their palm faced the wrong way in certain situations. In other situations, they sign it correctly. That kind of inconsistency, again, may denote a social dysfluency. We tend to find that if the dysfluency is deteriorating over time, that lends itself to be more of a medical or psychiatric type of dysfluency. It can also be very difficult when trying to diagnose dysfluency to rule out the influence an interpreter has. Again, we'll discuss this a little bit more on our unit on working with interpreters. But there may be dysfluency that is covered up by an interpreter. There may be dysfluency that you aren't able to observe or able to realize, and the interpreter doesn't know to inform you of it. So it can be very difficult to determine what's happening without figuring out what's happening with the interpreter as well. We also tend to see that if the fluency improves throughout the course of treatment, that is probably a medical type of dysfluency or a psychiatric type of dysfluency. One way that interpreters might deal with dysfluencies is by changing techniques that they use to interpret. For example, if a deaf person is more on the fluent or elegant side of the dysfluency spectrum, the fluency spectrum, the interpreter will tend to interpret more in a first-person type of narrative. As we go down to being more dysfluent, they may change to a third person or description. They may say, John is saying this and this and this and this, or John is using this word and this word and this word. It doesn't make sense to me, but here's what he's saying. When we get down to more the incoherent, minimal language skills, they may try to tell you basic concepts and descriptions of what that deaf person is signing. That deaf person is doing this with their hands. It's not really a sign I'm familiar with. It's not a correct sign. I'm not sure exactly what they're trying to communicate, but that type of thing. The difficulty with this is that most interpreters don't have specialized training dealing with mental health interpreting and may not know to do this. They may not know that they are able to use these different techniques. So it would be important to have those discussions with the interpreter. And again, we'll discuss that in more detail in our section on working with interpreters. We're going to shift our focus now to discussing literacy. So the first question to ask yourself is, how is literacy attained? Again, as a child growing up, learning, going to school, how did you attain your literacy? My guess is it probably started at home with your parents, reading books to you, maybe sharing stories with you, encouraging you to read books. Maybe you first began to learn literacy at school. You arrive at school, you talk to your teacher, you talk to your classmates in English, and you learn through a shared spoken language that you have with your teacher. Literacy is then the written form of that already shared spoken language. You may also use phonetics to learn how to speak. If any of you have ever watched Sesame Street, that's definitely how I learned, was Big Bird teaching me how to sound out words, or Oscar the Grouch teaching you, learning what sounds the different letters make and how to put those sounds together to form words. Now compare this to a deaf individual who may or may not have a American Sign Language fluency, who may or may not have any exposure to American Sign Language. They may go to the deaf school where they may or may not have a shared signed language with their teachers or with their classmates or with their peers. They may or may not have a shared sign language with their family. How then are they able to obtain a level of literacy or obtain an ability to comprehend written, spoken English? So a deaf child going to school where they may have absolutely no language base, they may have absolutely no shared communication skills or language with their teachers, the various competing educational philosophies out there, all of this will affect a deaf person's ability to obtain any level of literacy. Right now, the research suggests that the average deaf person is graduating high school at a 4th grade reading level. There are some variances to this, but on average, could an average 4th grader understand adult forms? Forms that we as mental health professionals may use, such as informed consent, financial forms, handouts dealing with mental health vocabulary, and topics. Keep this in mind when you're working with deaf or hard of hearing individuals, because a lot of times, again, as therapists, as psychiatrists, as doctors, even your physicians, we tend to rely a lot on handouts to provide information to our clients and patients. If that deaf or hard of hearing person does not have a level of literacy, that handout's not going to do them much good. Let's shift our focus to fund of information. What is it? We've discussed it a little bit so far, and you might already have an idea, but fund of information is the entire body of accumulated knowledge that a person has. This includes reading, which we just discussed about literacy, radios, movies, TVs, podcasts, overheard conversations, digital media. Most of this, if you think about it, is inaccessible to deaf individuals. Why is this fund of information topic even important? Think about this in terms of adaptive living skills. Things such as taking care of yourself, seeking out and obtaining transportation, a bus system, a taxi, getting your driver's license, learning the information you need to pass a test to obtain your driver's license, how to cook, how to shower, how to clean your house, how to take care of a pet. Think about yourself personally. Where did you gather most of the information to know how to do those things? Chances are it was through reading, watching videos. You may be a YouTube junkie. We have a psychiatrist that I've worked with for a number of years who refuses to pay anybody to do anything to his house because he can find a video on YouTube to teach him how to do it. Which is fine, that makes sense. But YouTube video is necessarily accessible to deaf individuals. Where do you get this information from that affects so many facets of your life? Think about social cognition, observing others and then mimicking that behavior. As maybe a high school or college student, how many times did you watch a movie and then take lines from that movie became something you and your friends told to each other and laughed and joked about for months and months and months? Think about health literacy, which we just talked about. How much information about health, about diseases, disease management, treatments, diagnoses, aftercare, when you're discharged from some kind of health or mental health setting. How much information have you obtained and learned through that fund of information or environmental learning? Oftentimes we find that deaf children are excluded from conversations with their parents and pediatricians. There's a lot of information, basic general information, that's missed when they are excluded. Take the time, and I'll give you just a second, to think about your own life, to think about all the various ways that you accumulate knowledge and you accumulate learning, period. And if just one of those were taken away from you, what kinds of things would you miss out on? What kind of learning or knowledge would you not have if just one of those facets were taken away? Now let's talk a little more specifically about that fund of information concept in healthcare. Now I'm going to talk about healthcare in general. Obviously, I mean medical healthcare and mental health care when we're talking about this. But let's talk a little bit about exclusions. As I mentioned a moment ago, oftentimes deaf individuals are excluded from family conversations about healthcare. They're excluded from, children are excluded from conversations between their parents and a healthcare provider in which they miss out on opportunities to learn. Think about talk around the dinner table. How much have you learned as a child or throughout your lifespan from conversations at dinner about your parents talking about grandparents or Aunt Mildred's health issues? How much family history have you gathered from conversations? Now to throw the statistic at you one more time, over 90% born to hearing families, over 90% never learning sign, communication not happening. They're excluded from that area of learning about family history, about medical history, about illness culture, knowing when it's appropriate to go to the doctor or when it's more appropriate to take a Tylenol and lay on the couch in front of a movie. What about sexual information, safety, STDs, things that are often taught in things that are often taught in health classes in school or are learned through literature for most hearing individuals, but are missed out for deaf folks. Oftentimes, deaf individuals are just excluded from participating in their own personal health care. It is sometimes seen as something that's done to me rather than something that I do to take care of myself. Along these same lines, think about education. There's limited education in schools for the deaf when it comes to healthcare and mental health. Oftentimes, again, in hearing schools, public schools, we have health classes that help to educate our children. In deaf schools, often these classes are replaced by auditory classes, speech classes, and classes along those lines. Think again about the literacy barriers. When you are feeling ill, how many of you have ever gotten on Google and punched in what was wrong with you and tried to read up on it? I'm sure most of you have. How many of you have gotten brochures from your doctor's office to find out about the latest, greatest treatment or technology that's available out there? How many times have you seen a commercial on TV describing medication and what that medication might be for? All of these things are excluded. This healthcare information is excluded from deaf and hard of hearing individuals. It's very common, particularly in healthcare settings, mental health settings, for myths to be perpetuated. I'll give you one example of this. One psychiatrist I worked with when I was a therapist in Kansas City, in his notes, he was working with a deaf youth, and in his notes, as a part of his formulation of a diagnosis, he wrote that this deaf child can lip read with me, but refuses to do it. He saw that as being rebellious behavior, as being almost aggressive behavior, and as being diagnostic criteria as he was formulating his diagnosis. When really, the deaf child could not read lips, but that myth was perpetuated in his notes. Same thing with literacy that we have been talking about this whole time. There is a common myth that if I hand a deaf person their informed consent, they will be able to read it, fully understand it, to the point where they can sign off and give permission and consent for me to provide treatment. There's also a sense of passivity among many deaf and hard of hearing individuals when it comes to their health care. That not understanding is the status quo. It just is what it is. I'm never going to understand my health care. I'm not going to understand the treatments, the medications. I'm just going to do whatever the doctor tells me. To kind of bring all this together for you as a wrap up to this unit, it's important to understand that having a limited fund of information is perhaps the number one consequence to being deaf or to having a hearing loss. But it is a necessary consequence. There are things that can be done to counteract this. As a mental health professional, you can take responsibility for ensuring that your client or your patient is fully understanding information you're giving to them. You can perhaps seek out resources to help communicate information to them in a more cultural and linguistic sensitive manner. I think you can see thus far in our training how this fund of information access has shaped deaf culture. The value that's placed on information, being very explicit and being very direct as being a part of deaf culture. I think you can see how fund of information issues are very prominent in healthcare, especially in mental health care, and that appropriate accommodations need to be made to ensure that communication and information is being shared and being understood by the deaf individual. Dysfluency definitely aggravates the inability to achieve a fund of information or to receive information. And interpreters alone are not going to be able to bridge that fund of information gap. It's going to take work on your part as the clinician to help provide and ensure understanding is happening. That brings us to the end of Unit 4. Thank you for watching. Again, if you have questions or comments, feel free to contact me at this contact information. Thank you.